Hello, Saviors. Today we are going to have a discussion on the topic which is extremely important as far as medical studies are concerned. अगर आपका फर्स्ट ईयर का एग्जाम्स है, you will be asked about the brachial plexus. In your final year, you will be asked about the clinical implications of the brachial plexus injuries. In your NEET PG and FMG examination, you will be tested on the questions related to the brachial plexus. Let us clear all the possible confusions that you might be having related to this topic, brachial plexus, for once and all. Although it might sound confusing majority of the times, but brachial plexus names of the component are designed after the arrangement of the tree. Like there are roots, as there are roots in the trees, there are trunks, as there are trunks in the trees, then we have got the divisions, and finally we have got the cords in the trees. So similarly, there are roots in the brachial plexus, and what these roots are, these are C5, C6, C7, C8 and T1. These are the roots of the brachial plexus. Now, the C5 and C6, it unite to form the upper trunk of the brachial plexus. The C7 root, it continues as a middle trunk of the brachial plexus, while C8 and T1, it unite to form the lower trunk of the brachial plexus. So there are three trunks in the brachial plexus. Each of the trunk now further divides into two divisions. Like there is going to be anterior and the posterior division of the upper trunk. There is going to be anterior and the posterior division of the middle trunk. And there will be anterior and the posterior division of the lower trunk. Why are there this kind of the arrangement leading to these divisions? Because anterior will supply the flexor compartment and the posterior has to supply the extensor compartment. Now, the posterior division of all the trunks, it unite to form the posterior cord. Similarly, the anterior division of the upper and the anterior division of the middle, it unite to form the lateral cord. The only division which is left is the anterior division of the lower trunk, which is continued as a medial cord. Now, the question that you might be having is, why or how are these cord named? Like in the case of divisions, we have seen the anterior and the posterior division. You see, anterior division is carrying the nerves or the innervations for supplying the flexor compartment. Similarly, the posterior division is carrying the innervations for the extensor compartment. Now, how these cords are named, the lateral cord, the medial cord, or the posterior cord, how are they getting named? You see, it is based on the relation with the axillary artery. If the cord is lying lateral to the axillary artery, it will be called as lateral cord. If the cord is lying posterior to the axillary artery, it will be called as posterior cord. While if it is lying medial to the axillary artery, it would be called as medial cord. And at this point, you also came to know the origin of these cords. Now, once you are aware of this arrangement, next, the thing that you have to remember from the anatomical perspective are the branches. You know, there are several of the branches which are emerging right from the roots of the brachial plexus, like nerve to latissimus dorsi, nerve to rhomboides. It is all beautifully given in your BD Chaurasia books. Similarly, the nerves which are emerging from the upper trunk of the brachial plexus, like suprascapular nerve, the dorsal scapular nerve, then are the nerves which are emerging right from the cords of the brachial plexus. Like there are 5 branches which are emerging from the medial cord, there are 3 branches which are emerging from the lateral cord, and there are 5 branches or the 5 nerves which are emerging out from the posterior cord. Now, this is all the anatomy that you must be aware of. What we are going to have a discussion on is the clinical implications of the brachial plexus nerve injury. You see, the brachial plexus nerve injury can be categorized into two. One is a specific injury to the brachial plexus. That means injury to the root of the brachial plexus, for example, or injury to a single nerve like dorsal scapular nerve, or injury to the radial nerve, or injury to the upper trunk of the brachial plexus, or injury to the long thoracic nerve of Bell. Now, these are all specific injuries to the brachial plexus that we would be talking about later. The first thing that we have to deal with is the thing which is more clinically, that is happening more commonly, which is more important from the clinical perspective, is the non-specific injury to the brachial plexus. That means overall out of this brachial plexus, any of the structure could be injured. So how the patient will be presenting to you with a non-specific injury to the brachial plexus? You see, before we talk about the clinical features of these non-specific injury to the brachial plexus, let's have a segmentation of where exactly inside the brachial plexus these injuries can happen. You see, once the nerve is coming out of the spinal cord, then the dorsal fiber relay its neurons into the dorsal root ganglion. An injury to the brachial plexus can happen either proximal to this dorsal root ganglion or distal to this dorsal root ganglion. Now, if the injury is happening proximal to this dorsal root ganglion, it would be called as preganglionic injury to the brachial plexus. While if the injury is happening distal to this dorsal root ganglion, it would be called as postganglionic injury to the brachial plexus. So point number one, the simple distinction is that the site of the lesion, if it is proximal to the dorsal root ganglion, it would be called as preganglionic. While if it is distal to the dorsal root ganglion, it would be called as postganglionic. Simple. So these are the two types of non-specific injury to the brachial plexus. Point number two is, what are the common mechanisms? Obviously, a very high velocity trauma will result in avulsion of the roots from its spinal cord, leading to the preganglionic injury. So most of the time, it is the avulsion injury to the brachial plexus or root because of the preganglionic injury. Now, the postganglionic injury, what happens? It could be a tractional injury, it could be an incisional injury. So, if there is a stretch, if there is a compression, or if there is a penetrating trauma, that might result in the segmentation or a stretching or compression of the spinal nerve, that becomes the mechanism of injury for the postganglionic brachial plexus nerves. Now, the most important part that you have to remember as far as this clinical distinction is concerned is the sensory loss. You see, if the nerve is injured over here, then obviously there is going to be a loss of tactile sensations. But if the nerve is injured right at the level of the root of the spinal cord, then there is a possibility of intact sensations despite having a root avulsion. Why? Because the sensory nerve nuclei is present in dorsal root ganglion. Because the sensory nerve, they are completing their circuit all the level up to the dorsal root ganglion. So there is a possibility that the patient might be having a intact sensations. While on the other hand, in case of postganglionic injury, there will be a loss of sensations, means the patient won't be able to feel anything. So that is a very, very important clinical distinction point on the basis of which you will make the diagnosis of preganglionic injury to the brachial plexus clinically. Point number four, motor loss. Now, in any case, whether there is a avulsion at the level of root, or if there is a bifurcation or compression or stretching beyond the level of the ganglion, there is going to be a motor loss. So both preganglionic and postganglionic injury would be presenting with a flail limb motor loss. Although this motor loss could be slightly variable in case of postganglionic injury, because there is a possibility that not all fibers are damaged. But yes, motor loss is present in both these two cases. Now, if you combine both of them, if in a question it is mentioned that the patient is coming to you with a motor loss, but the sensations are intact, then it goes in the favor of preganglionic injury to the brachial plexus. While on the other hand, if there is another clinical scenario where the patient is coming with the loss of sensations along with loss of motor function, then possibly we are talking about the postganglionic injury to the brachial plexus. So that is part number one, on the basis of which both these two injuries can be distinguished. Now, another point is pain. You see, if there is an avulsion fracture, obviously from the root, so the patient is going to experience a severe neuropathic pain. So there is going to be a severe pain in case of preganglionic injury to the brachial plexus. But on the other hand, that pain could be variable, means that patient could be having too much of the pain or relatively less pain. It depends upon the severity of the damage that has happened in case of postganglionic nerves. So it could be a variable pain in both of them in postganglionic injuries to the brachial plexus. Now, the sixth point obviously is the paraspinal muscle EMG. How the paraspinal muscle react. You see, the nerve supply to the paraspinal muscles is originating right from the dorsal part of the roots of the spinal nerve. That means it is nearer to the spinal cord. And if there is an injury, that is preganglionic injury, which is nearer to the spinal cord, then there is a possibility of paraspinal muscle palsy. So in these cases, there is going to be a denervation which can be observed on EMG studies if it is subjected on paraspinal muscles. That means paraspinal or the central diaphragmatic muscles, they become paralyzed in case of preganglionic injury to the brachial plexus. While in case of postganglionic injuries, the central muscle paralysis is not there. That means the paraspinal muscle palsy is not there. So the EMG studies, it is absolutely normal. Then the seventh point and the interesting one is the presence of the Horner syndrome. Now, majority of you are aware what are the features of the Horner syndrome. Like there will be ptosis, there will be meiosis, there will be anhidrosis, there will be an ophthalmos, and there will be a loss of ciliospinal reflex. Now the point is that how this Horner syndrome, which is related to ophthalmology, comes to become a part of preganglionic injury to the brachial plexus. You see, the T1 is a first sympathetic pathway to the eye, and it is committed to the functions of the eye. And through the T1 roots or through the T1 nerves, the sympathetic system of the eye runs. That means ocular sympathetic system, it runs on T1. That is the first segment of the sympathetic pathway. Now, whenever there is a sympathetic requirement in the body, then there will be dilatation of the pupil. That means there will be mydriasis, there will be exophthalmos, there will be ciliospinal reflex. That means whenever you are running, your eye comes to function in coordination with your motor reflexes or the functions. So this is how the sympathetic system works. But imagine if there is an injury to this T1, so there will be a loss of sympathetic drive to this eye, as a result of which exactly opposite features happen. So what happens? That there will be a meiosis instead of mydriasis. There will be an ophthalmos, there will be drooping of the eyelid, there will be loss of ciliospinal reflex and anhidrosis. So all of them are the features of the loss of the sympathetic pathway to the eye because of the involvement of T1 root. That is why Horner syndrome is a possibility in case of preganglionic injury to the brachial plexus. While in case of postganglionic injury, because it is happening after the dorsal root ganglion, there is obviously no involvement of the T1 root. Roots are not getting affected, right? So Horner syndrome is a possibility. So till this point, if at all we have to compare the preganglionic and postganglionic injury to the brachial plexus, then what are the points? Point number one, both of them are going to have the motor deficit. Point number two, the sensations would be intact in case of preganglionic, but the sensations would be lost in case of postganglionic. Point number three, the central or the paraspinal muscle palsy would be present in preganglionic, but it would be absent. That means there will be normal functional paraspinal muscles in case of postganglionic. And point number four is the presence of the Horner syndrome. The Horner syndrome would be present or could be present in case of preganglionic, while it would be absent in case of postganglionic. Next point is that how will you diagnose this condition? Imagine there comes a patient in the emergency with a flail upper limb, no movement at all, and you have to make the diagnosis whether the patient is having or suffering from the preganglionic or postganglionic injury to the brachial plexus. So the investigation of choice obviously would be the MRI. And how will you identify this thing on the MRI? You see, there will be a root avulsion. From the spinal cord, the roots are getting avulsed. So if there is an avulsion of the root, obviously, then there will be a collection of the CSF beyond the margins of the dura. And if there is a collection of the CSF beyond the margins of the dura, it can very easily be depicted on T2 fat suppressive images. As we have already talked in previous of the lectures, that on MRI, when the water appears white and the fat is getting suppressed, these are STIR images or T2 fat suppression images on which CSF can be very easily seen beyond the margins where it should not normally be present. So this is known as pseudo-meningocele. That is one of the findings. That means the nerve roots cannot be identified because they are avulsed. Instead, there is a presence of fluid right at the junction of the root with the spinal cord. So this is pseudo-meningocele which is usually present. So in case of MRI, the pseudo-meningocele is a very common observation. While in postganglionic injury to the brachial plexus, what you tend to see that the nerve root can as easily be identified on the MRI, Although there could be some edematous changes if at all there is a compression, there could be a loss of continuity if at all there is a sectioning, or there could be a edema, there could be inflammation in case if they are subjected to a tractional injury. So all these things can be identified again on T2, T1 contrast enhanced images. As far as pseudomeningocele is concerned, you know that because the dura is pierced near the spinal cord because of the avulsion of the root, so pseudomeningocele would not be a finding in case of the MRI for postganglionic injuries to the brachial plexus. So as you can see that this pseudomeningocele can be seen where CSF is leaked out beyond the margins of the meninges, can be seen in case of preganglionic injuries to the brachial plexus. As far as potential recovery is concerned, as you know, it is no spontaneous recovery documented for preganglionic injuries to the brachial plexus because it is considered to be a high significant injury to the brachial plexus, leading to the avulsion, leading to the disconnect. While if the injuries are of axonotmatic type, or if the injuries are of Sunderland type 2 or type 3 type, then spontaneous recovery is possibility or is possible in case of postganglionic injury. It does not mean that it will happen all the time. Then obviously if you have to go for the nerve repair, then it is not a possibility in case of preganglionic injury, but in case of postganglionic injury you can go for nerve repair. But you know, if MRI has depicted a postganglionic injury to be a tractional injury, to be just a compression injury, then one of the splints which is very frequently asked in the examination, particularly in the NEET PG examination, that what is the name of the splint which is used for the brachial plexus injuries, it is aeroplane splint. But by this time you might have identified that aeroplane splint is particularly useful where the brachial plexus injuries are to be managed conservatively. And as far as the prognosis is concerned, now it becomes much easier for you to understand that the preganglionic injury would be presenting with a very poor prognosis, while postganglionic injury would be presenting with the relatively better prognosis. I'm not saying that it would be having a good prognosis, but relatively better prognosis. So if you compare the pre and the postganglionic injuries in 5 points, point number 1, that if there is a loss of sensation with the loss of motor activities, it is postganglionic. Conserved sensation with loss of motor activity, it is preganglionic. Horner syndrome is a feature of preganglionic. Similarly, conserved paraspinal muscle activity is the feature of preganglionic. Poor prognosis is a feature of preganglionic, and pseudomeningocele formation on the MRI is a feature of preganglionic. These are the 5 points. If at all the examiner asks you that what are the 5 points, or write the 5 points in differentiating the pre and the postganglionic injuries to the brachial plexus, you'll get 10 out of 10. Now is the time to have a discussion on the specific injuries to the brachial plexus. And you know, out of multiple types of the injuries that can happen, obviously we are not going to talk about the branches injuries. The 3 most common injuries which are very frequently asked are the injury to the long thoracic nerve of Bell, because it is one of the nerve which is emerging right from the root of the brachial plexus. Second is injury to the trunks, and in the trunk particularly the injury to the upper trunk or injury to the lower trunk. So these are the specific injuries to the brachial plexus. Now the time to have a discussion on, because it is again very frequently kept in your examinations. So as we are going to talk about the roots of the brachial plexus, the two nerves which are emerging out of the root of the brachial plexus is nerve to serratus anterior and nerve to rhomboides. But it is the serratus anterior in particular that the examiner tends to ask you. Now, why is it called by the name of nerve to serratus anterior? That means because it is responsible for supplying motor activities to the serratus anterior muscle. Now the next question is, why this serratus anterior muscle is called by the name of serratus anterior? Serra in the Greek word is used for saw. And if you look at the arrangement of these muscles, so these muscles are appearing like a saw where they are getting originated from the anterolateral end of the ribs, particularly the first 9 ribs, and they are getting inserted onto the medial border of the scapula, onto the medial part of the scapula. So they are in their static activities, the serratus anterior muscle in their static activities are responsible for holding the scapula against the chest wall. Because of the medial contraction, they are responsible for holding the scapula against the chest wall. So this is providing the stability to the scapula. Now, as far as the dynamic function of the serratus anterior is concerned, it is responsible for pushing and particularly the pinching. So these are the two movement related function. But for the structural stability, it is pulling the scapula against the chest wall. The other name which is given to nerve to serratus anterior is a long thoracic nerve of Bell. As all of you are aware that it is also known by the name of long thoracic nerve of Bell. Why so? Because it is the longest nerve in the thoracic region. That is point number one. That is why it is called by the name of long thoracic. Why called by the name of nerve of Bell? Because Charles Bell has identified that if there is an injury to this long thoracic nerve of Bell, it will result in winging of the scapula. So all of you are aware that the palsy of the serratus anterior or injury to the long thoracic nerve of Bell will result in winging of scapula. Now, what can happen in the examination is that the examiner can give you this image and then he will ask you to identify that whether it is winging of scapula or not. Point number two, you have to know about the differential diagnosis, that if such image is provided to you, is it winging of scapula or not? Now try to understand. You know what we have studied in serratus anterior? It is responsible for pulling the scapula against the chest wall. So bringing the scapula against the chest wall because it is getting inserted onto the medial border of the scapula. Now imagine if the serratus anterior muscle function is lost. So what will happen? The medial border of the scapula will become more prominent. Why it will become more prominent? Because the serratus anterior muscle is not able to pull the scapula against the chest wall anymore. So there will be medial border prominence of the scapula. So this is how you will identify winging of a scapula. Now let's talk about another image which is kept in the same picture, and it appears on the first stance that it appears that I'm looking at the image of the winging of a scapula. Now is it winging of a scapula? Now let's see. Point number one. Are the level of the scapulae similar? No. The level of the scapula is higher in comparison to the other. That is point number one. Point number two is that the abnormal scapula is appearing relatively broader. So these 2 points are more than enough for you to distinguish this point B condition with winging of scapula. So what this B condition is? It is Sprengel's shoulder. You know, Sprengel's shoulder is a congenital abnormality where there is failure of descent of the scapula, as a result of which one of the scapula remains higher in comparison to the other, and this is altogether a different abnormality, not the winging of a scapula. But when we sit in the examination hall, when we get this image, then there is a possibility that we might mark the wrong answer as winging of a scapula. So be ready for these kind of the distinctions, because image over here is not winging of a scapula, it is a Sprengel shoulder, while over here we are looking at the image of the winging of a scapula. And in winging of a scapula, obviously it is not an abnormality of the asymmetry as the level of the scapula, so both of them are going to be at the same level. I hope you have understood everything related to winging of a scapula. Next is injury to the trunk of the brachial plexus, and in the trunks particularly we'll be talking about injury to the upper trunk of the brachial plexus. You know, the upper trunk of the brachial plexus is also known as Erb-Duchenne palsy. Why is it known by the name of Erb palsy? Because Erb has identified the nature of injury, or sorry, where the trunks are getting originated from the root. At this junction, these injuries are particularly happening. So this mechanism of injury was provided by Erb, and Duchenne has identified the clinical feature. So in combination, it is called by the name of Erb-Duchenne palsy. Point number two, as we have already talked about, that this injury typically occurs at the junction of the roots and the trunk. It is again, most of the times, it could be a tractional injury or it could be a avulsion injury, but more commonly it is a tractional injury. Now point number three. Now this is something which the examiners asks you multiple of the times, that what are the names of the nerves in particular which are involved in Erb's-Duchenne palsy. So one is the suprascapular nerve. You know why? Because suprascapular nerve is originating from the upper trunk of the brachial plexus. The second one is the nerve to subclavius, because it is again originating from the upper trunk of the brachial plexus. Rest of the nerves are the musculocutaneous and the axillary nerve. Why both these two? Because of the direct involvement of C5 and C6, where there is a dominance of C5, C6 contribution to the nerves. Next point related to this abduction palsy is the mechanism of injury, because every time in the examination the question is asked, it is going to be a long clinical question where the mechanism would always be provided to you. And particularly these types of injuries are very, very commonly seen in case of newborns, which is because of the obstructed labor, where what happens is that this shoulder gets stuck under the pubis of the mother, that the shoulder, it gets stuck under the pubis of the mother, thereby creating a obstruction. And if a untrained dye, or if the untrained assistant is trying to pull the baby out, then what she will do, what she might do is the excessive separation of head and shoulder, that there might be a deviation of the head in the opposite side, leading to a tractional injury while pulling the shoulder downwards when the neck is forced to the opposite side. Now this might result in the tractional injury to the upper trunk of the brachial plexus, and that is why it is very, very commonly seen while performing this obstructed labors. It is also said to be a birth injury due to shoulder dystocia, where the shoulder of the newborn gets stuck under the pubis of the mother. So that is one common mechanism that majority of you are aware of, is usually kept in the examination as a hint for you to reach the diagnosis. Now, another point related to the Erb's palsy is what are the names of the muscles which are getting affected. As you know, deltoid, which is responsible for continuation of the abduction, would be affected. Why? Because deltoid is supplied by the axillary nerve that we have talked about. Point number two, the supraspinatus and infraspinatus. You know that supraspinatus is responsible for initiation of the abduction, while infraspinatus is responsible for the external rotation. Both of them are supplied by suprascapular nerve, and both of them are going to be affected. So the patient is going to have a loss of abduction and loss of external rotation at the level of the shoulder. So these are the two abnormalities at the level of the shoulder the patient would be presenting with. Point number three, the biceps brachii muscle, which is supplied by musculocutaneous nerve, is having a function of flexion and supination. So supination and flexion would also be affected because of the musculocutaneous nerve injury, thereby biceps brachii palsy. Then there will be an injury to the brachialis also, which is again attributed to the musculocutaneous nerve injury, which will result in loss of elbow flexion. Now, if you combine all these clinical features because of this loss of muscle action, then you will be having, then what you are left with, that there will be loss of abduction, there will be loss of external rotation at the level of shoulder, there will be loss of flexion of the elbow, and there will be loss of supination of the forearm. So these are the four losses the patient is suffering from because of affected these set of muscles. Then finally, how the patient would be presented to you. Obviously, if the patient is not able to abduct the arm, it will be kept adducted. If the patient is not able to externally rotate the arm, it will be kept internally rotated. If the patient is not able to flex the elbow, it would be kept extended. And if the patient is not able to supinate the forearm, it would be kept as pronated. So this is how the patient would be presenting with the abnormality, and this is known by the name of Erb's palsy, also known by the name of policeman tip deformity or waiter tip deformity, as if the person is asking for a tip in a hidden manner or in a hidden way. So hopefully everything is clear related to the attitude. You already are aware of this, that it is known by the name of policeman tip or the porter tip or waiter tip deformity. And why this deformity is happening? Because of these reasons. There will be loss of abduction of the shoulder, there will be loss of external rotation of the shoulder, there will be loss of flexion of the elbow, and there will be loss of supination of the forearm. And then finally, we'll be talking about injury to the lower trunk of the brachial plexus. You see, injury to the lower trunk of the brachial plexus will result in two of the clinical features. One is a claw hand and the other one is Horner syndrome. Why? Because lower trunk of the brachial plexus is made up of C8 and T1. And as we have already talked about, that T1 is responsible for supplying a sympathetic drive to the eye. And if there is an injury to the T1 roots, then it will result in a loss of sympathetic function to the eye. And loss of sympathetic function to the eye is identified by these five clinical features. One is ptosis, meiosis, anhidrosis, loss of ciliospinal reflex, and enophthalmos. So that is one point. Point number two, in case of Klumpke's palsy, there will be a loss of intrinsic muscle function to the hand, which are innervated by C8 root. So, as a result of which, there will be a loss of particularly the lumbrical function. Now, how this Klumpke's palsy is different from the ulnar claw, because in case of Klumpke's palsy, there is going to be a complete claw. That means all the four fingers would be affected. It is going to be a complete claw. While in case of ulnar claw, there is going to be a clawing of the medial two fingers in comparison to the lateral two. So this is the major distinction in between the two. Now, why is it known by the name of Klumpke? As you already know, that after the name of the person who has identified this disease and the clinical features. So I hope that this topic, brachial plexus, right from its anatomy all the way up to its clinical implications, is clearer. You are able to answer any question related to the brachial plexus anatomy that you have to practice multiple of the times. Then non-specific injury to the brachial plexus is something that probably you might not have heard about before this lecture. So you also came to know about it. And point number three is a specific injury to the brachial plexus that you tend to learn it multiple times, but until and unless you are not ready with the name and set of the muscles affected, then there is always a possibility that you might answer the question wrong. Thank you very much for listening the session. All the best for your future endeavors.